Well, good evening. Tonight we will enjoy a lecture by Dr. Laura McCrary on KONZA, named after the KONZA Prairie at the Flint Hills in Kansas. We know Dr. McCrary because she's visited us frequently as a representative of One Health. Now, in the introduction to our talk, you may have noticed some alphabet salad, and let me try to debunk that. There is an office of the National Coordinator of Health Information Technology called ONC, and that person has put together a trusted exchange framework and common agreement called TEFCA, last released in November of 2024, that sets the perimeters for a regulated data exchange. And under this data exchange, there are various qualified health information networks, QHINs, and KONZA is one of the most prominent of those. Now, talking to us about it will be Dr. McCrary, who has a doctorate in education, administration from Kansas State University, and has completed postdoctoral work at the University of Kansas. She holds a master's degree in learning disabilities and emotional disturbances, as well as a bachelor's degree in education, and she'd be the right person to educate us in these matters. With that, Dr. McCrary, I give you the microphone.
Thank you. Thank you very much, Dr. Blumenthal. It's just wonderful to have the opportunity to meet with all of you this evening. I'm coming to you from Kansas. As Dr. Blumenthal mentioned, my home is in Kansas. I went to KU and to Kansas State University, and our company is named after the KONZA Prairie, which is the last remaining tallgrass prairie in the nation, and does indeed have buffaloes and continues to have a wide variety of educational and research opportunities around one of the last remaining tallgrass prairies. So it's wonderful to get to spend some time with you this evening. I've known Larry and Josh now for many years, and some of you may have actually attended some of the trainings that I did in person there in New Jersey prior to COVID. I really spent quite a bit of time there. And so I'd like to go ahead and just get started. This is going to be a fairly informal presentation for all of you. I'm going to be pausing to ask and see if you have any questions. And I am planning on having a Q&A time at the end of the presentation. So let's go ahead and get started. So KONZA Health is the name of our overarching company. And then underneath that, there's a series of state-based organizations really sponsored by the state medical societies. So One Health New Jersey has been a sponsor of a health information exchange in New Jersey. Really, I can't even remember for sure, Larry, but I would say that it was probably 2018, maybe even 2017 that we started working together in New Jersey. And we have many other states that we work directly with the medical societies. I have the privilege of meeting with the executive directors of those. We started in Kansas with KHIN back in 2010, and then moved to Georgia when the Georgia Medical Society asked us to come and work there. And really the whole goal was to help independent physician practices be able to participate in health information exchange, in interoperability, in the same way that large hospital systems or even larger practices were able to do at that time. And independent physicians have generally been often left out of being able to really participate in some of these national initiatives. So South Carolina came next, and then Connecticut, and then Missouri. HealthSync is Louisiana. Max is Mississippi. Sac Valley MedShare is Northern California. And Genesis Link is Texas. So one of the things that is important about what we're going to talk about today is really the engagement of physicians now In value-based payment models, we know that CMS is expecting all physicians that are involved in Medicare or Medicaid to be in value-based payment models by 2030. Now, I mean, that still seems like a long way away for me, but it's not that long. And there's work to be done to be ready to be in those value-based payment models. Really, what one of the things is there has to be secure exchange of medical record patient information between doctors who share the same patient. You know, today we rely far too much on the fax machine and far too much on PDF documents. Some of you may have heard and I'll make this a short story, but my horror story about the fax machine when I was in Manhattan, Kansas, as a student at the university. A very, very prominent physician who had a very well thought of practice. All of the medical records from his practice were found in the local dump in the area where people brought all of their trash. And upon investigation, it turns out that the fax machine that had been assigned to the local lab company called Peterson Lab had changed to a Mexican restaurant. And the Mexican restaurant didn't know what to do with all of these medical records that were coming across. And they just put them in the trash and they got taken out to the local dump. So the new electronic medical record exchange prevents that from happening. We don't see that kind of faxing or PDFs any longer. It's secure and it's safe and it's quick and it connects everybody together. And when that happens, patients get better care and physicians have better information to be able to make decisions about. So who is KONZA Health? So we are the vendor to One Health New Jersey. So we sit behind Larry and we make all of the technical work actually happen. We're a private, not-for-profit organization. We're not government run. We're provider-led and provider-governed. We were set up by doctors for doctors. We were designated as a qualified health information network. And what that means is that we have the highest standard of interoperability and the highest standard of security and the highest standard of regulation in the nation. And so we also care very deeply that the data that we share across our network is complete and correct. And to that end, we take all of the practices, all of you who are on this call will take those practices through what's called NCQA DAV, Data Aggregator Validation Accreditation, to make sure that the data that you are sharing is complete and correct. We also have the highest standard of security in the nation. And we have High Trust, MARS-E, ENAC, and we also go through every year internal and external penetration testing. So let me pause and just see if there's any questions at this point that anyone would like to ask. Okay, hearing none, I'm going to go ahead and keep going. You guys, you can keep them all till the end because we'll have some time at the end as well. So let me just tell you a little bit about who we are. I think you know Larry and you know Josh, but our team that would be working directly with you if you participate is obviously myself. I'm the president and the CEO of the company. I've been here since its inception. I was hired by the Kansas Medical Society to actually build and run this exchange. And we've been doing this now for 15 years. We have 15 years in this business. And I'm supported by nurses, both Rhonda and Melissa are both nurse informaticists, and they work directly with all of our practices to make sure that data is correct and that the workflows that you're using in your practices really maximize the value of the health information exchange and of all of the data that you have and are receiving from across the nation. And Jody and Sarah, they're there as the people who will support you on the technical side of the work. So we support you with nurses on the clinical side, and we support you with technical folks on the technical side to make sure that this is done smoothly and easily with as little barriers as possible to your practice, because we know that we don't want to disrupt your day-to-day work. So KONZA and One Health New Jersey really provide 3 sets of services to you as providers in New Jersey. The first one is called QHIN services, and we're going to talk about each one of these in depth. And so we're going to go into it a little bit more. But QHIN service is really that nationwide interoperability to make sure that your patient who just got back from Disneyland and their daughter had to go to the emergency room, and now she's bringing her daughter in to see you, and she can't remember what the medications were that were actually prescribed. And so the QHIN allows you to access information from that hospital system excuse me, just for a minute, my dog's telling me that she wants to be lifted up on the couch. There you go. So that interoperability that allows you to be able to get the information from Florida to be able to care for your patient who has been admitted to the emergency room there. Data delivery services, in this new world of value-based payment models, you are going to have to move data, not only to payers to be able to demonstrate that you've met the quality measures that the payers are requiring, but also if you're working with a hospital system, they may be trying to meet specific kinds of quality measures at the hospital level. And then the health plans are also trying to meet quality measures. So it goes all the way up the chain, from the physicians to the hospitals to the health plan. They all have to meet about the same set of quality measures. And the fact that that woman that is your patient got a mammogram or got her colorectal cancer screening at your primary care practice, that is critically important for everybody to be able to ensure that the quality measures are met and reimbursement is obtained at the highest level. And then we provide analytic services to you. So a lot of the organizations in value-based payment models really need to know what's happening when their patients, outside of their own practice. Have they actually been to the hospital? Have they been readmitted within 30 days? Have they actually been transferred to a skilled nursing facility? These are all things now that are really important for practices and doctors to know. And this is a big part of what we do. So let me stop, see if anybody has any questions. All right, moving on. Let's talk about this thing called a QHIN. And that QHIN stands for Qualified Health Information Network. And I want to tell you a little story. About 2 weeks ago, I was on vacation with some of my girlfriends. We take a vacation every year. And we were in Mexico, and I got a call from a number that I didn't recognize and from a woman that I didn't recognize. And the woman said, "We need to have you in Washington, D.C. at the White House on Wednesday." And this was Monday. And I was in Mexico. And I kind of thought, this is a joke. Why would anybody really need for me to get to the White House in one day? And as it turned out, it was not a joke. It was very serious. And the person that was calling me was Amy Gleason, and she is the acting director of DOGE. And what she wanted was for us and the other leading technology companies in the nation to get to the White House on Wednesday, because the president wanted to address us in terms of the importance of interoperability and the importance of the networks that we have built and put in place. And One Health New Jersey is one of those networks. And what he wanted to tell us is this is a critical priority for our administration. And we are establishing what's called CMS aligned networks. Now, what they didn't say out loud, but it was in their template, is that any organization that bills Medicare and maybe Medicaid, they didn't come out and say that, will need to participate in a CMS aligned network. And so the QHINs are the same as the CMS aligned networks, which is why they rushed me to Washington, D.C. And I do have to tell you, I was pretty impressed that I actually got the opportunity to go to the White House and be able to we didn't actually get to meet the president, but we did get to meet Dr. Oz, and we got to meet RFK, and I actually have a certificate that they presented to us, which is going to be kind of hard to see. Let me see if I can get this, which says make health tech great again. So you can tell that's probably from the president, make health tech great again. But what this means to me, and I think needs to mean to you as physicians, is it really doesn't matter what the administration is, whether it's a Republican administration or a Democratic administration. What is happening now is everyone understands the importance of sharing data. And that's what the Designated QHIN does, as well as the CMS-aligned networks. If you wondered how I happened to have any clothes that were appropriate to go to the White House after being on vacation in Mexico, just let you know, I did not. I had to go buy some. And so, but there were other people besides me that had one day to get to the White House that also didn't have appropriate clothes. So let's talk about this a little bit more. Nationwide exchange, we already talked about the little girl who was down in Florida at Disneyland, who's your patient. Centralized record, so now you're starting to see where all of the records for your patient from all of the different places that she's received care at are in one longitudinal document. It's deduplicated, it's normalized, you're able to look at it and use a table of contents. You're not trying to look through 20 or 30 documents. The goal here is to give to the doctors the information that they're going to need to be able to be successful in caring for that patient quickly and accurately. And that's what One Health does. So we're different from some of the other QHINs. And let me tell you, those QHINs are QHINs like Epic, they're like Cerner, they're like Athena, they're like ECW. And what we do is we actually do queries nationwide to make sure that your patient's data from wherever they've been at is pulled back and made available for you. Not all QHINs do that. So as you're starting to think about what QHIN do you want to participate in, I think that's an important consideration. The other thing is that we will eliminate, we will eliminate the burden of all of the transactions from all the QHINs across the nations hitting your practice. What does that mean? Well, it's estimated that as soon as the QHINs are fully implemented, and there's about 50,000 organizations today that participate in the QHINs, but that's only about a third of all of the organizations nationwide that will be participating. Think about yourselves. If you're not participating in a QHIN now, you're not being counted in that 50,000. It's estimated there will be 40 million transactions a day across the nation. I think most of you don't want to have to respond to 40 million transactions. And so what we do at One Health is we sit on top and we make sure that we respond to those transactions for you so that you don't have to worry about them. That's very important and something that you do need to be thinking about when you choose a QHIN. Now, One Health and KONZA, we support all organizations in our QHIN. We support, those of you who are in value-based payment models. We support providers and we support pharmacists and pharmacy, payers and health plan. Some states and regional HIEs want to connect and join through us. And then we also support public health. So just so I can be really as clear as I possibly can with you, the QHIN infrastructure will be the way in the future that all data is shared. So while there's still some state-based HIEs, really, they're all moving to participating in QHINs, or now with the new administration called CMS-aligned networks. So let me stop and see if there's any questions.
My name is Nicole. Hi.
Hi.
With Summit Health, which is former SFG, AMC, and then Village MD that you purchased. I think one of the frustrating things is we started with value-based care programs and then they kind of stopped. So primary care first. ramping up and getting all that done, and then now they've just stopped doing. How flexible are you if we're in one value-based? You know, like if we're in one program and then we need to change the data.
We're very flexible. This is your data and your patient's data. And so wherever you as a physician or as a practice tell us to send that data, we will send it to that organization. And we recognize that there are a number of, I guess I would call them vendors that provide value-based services, like Innovacer, Acadia, some of those are out there. And so we send data to those, your clinical data to those, in order to make sure that you can be successful in whatever value-based model that you move into.
Like a layer on top of.
Yeah. Yeah, that's right. We sort of sit on top of your EHR and we intercept the data that's coming out of your EHR and we send it to where you tell us.
You said you work.
Oh, I'm sorry. I think you broke up.
Are you working with Athena? Is that what you mentioned?
Yes, we are working with Athena, and we have several Athena hubs. And Athena is actually one of the easiest and the most cost-effective EHR vendors as it relates to interoperability. Okay, moving on. I will just say again that one of the things that we found that doctors really were concerned about is they would receive lots and lots of encounter level documents. So let's say the patient had been at the hospital. They would get maybe 5 documents for the hospital for the patient. Let's say the patient had been at a specialty care doctor. They would get another 5. Let's say the patient had been at a primary care doctor. Then there was another 4. And so really, it's almost impossible for a doctor to open each one of those up one at a time and look at them, try to jot down the medications. So what One Health does with its technology is it pulls all of that data together in a very nice deduplicated and normalized document. We use a company called Availity to produce that document. It's a leading insurance clearinghouse and revenue cycle management company. It's owned by a number of health plans, but they produce a very nice document that can be used by doctors very quickly and effectively to determine what is the status of a patient's health. So it's one of the things that we do really well, and I think it's one of the things that is going to be important to all of the physicians as they start to receive more and more and more data. And we can take data in any way. For example, a lot of physicians don't want to come out of their electronic health record system and log into another portal somewhere. That's very disruptive, really, for the physician, for their nurse, for the patient. So we bring that data, One Health brings that data right into their EHR system. Excuse me. And Athena has a very nice product that allows that data to come right in and for you to be able to view it. So we can take data in lots of different ways and display it in lots of different ways for you. This is kind of some people like to see data architectures, but I'll just spend a minute on this. Basically, this is the way our infrastructure works. So we receive data over on the left-hand side from all kinds of organizations, and that data generally comes through in what's called HL7v2 data feeds, or it comes through in CCDs. Here pretty quickly, we're going to add a new data model there, which is called FHIR, Fast Healthcare Interoperability Resources, or FHIR. And so we'll all be moving to FHIR over the next 10 years, and we'll be adding this here. So all of this data comes into our KONZA integration engine sitting right here in the middle. And then it goes out to lots of different places. It goes out to personal health records. It goes to our data warehouse. It goes to, it goes to public health agencies. Whoops, what happened there? It'll also go out to other organizations like QHINs through this, through the data gateways and through the KONZA QHIN. So there's lots of opportunities to really think about how this data moves. So let's spend just a minute talking about data delivery services. And I think that the doctor that was just asking me that question, it was a very good segue into this. Because how does the data get out of your EHR and to where you need it to get to, right? Is it to a vendor that's really helping you with your value-based with your value-based programs? Is it a health plan that's asked for that data to be able to demonstrate the quality of care that you're providing? Is it to another organization that's providing care to the same patient? These are all the ways that we make sure that the data gets out of that EHR and is delivered safely and securely to the other organization. So we do have a web-based portal. We like to consider that to be a last alternative. But there are a lot of organizations that you might be working with as a physician that might not have an EHR. I was just talking to an organization in Connecticut, and they sent me the list of all of their practices. It's a value-based contracting organization. They had about 100 practices that were part of it. And of the 100 practices, there were 12 that were still on paper. I mean, so if you're still on paper and you haven't digitized your medical records, you have to use something like a web-based portal to be able to see the information on your patients. And so the web-based portal is easy for anybody to use. It's safe, it's secure, it has multi-factor authentication, and you just log in with your username and password and you complete the multi-factor authentication, and then you're able to search for each one of your individual patients. You're also able to make very closed loop referrals to other physicians. So for example, if you needed to refer that patient to a specialist, then there's a very it's called direct messaging structure within that portal that allows you to choose from a drop-down list and to be able to send all of the medical records through that portal to a specialist that you would be referring the patient to. So it's really, while it's not our first choice because we want doctors to stay within their EHR systems, it's a good choice for doctors who don't have an EHR, or for home health agencies who have nurses in homes that just are using a tablet, or for organizations that are, for example, post-acute that don't have an EHR. It allows all those organizations to be able to see the information from your physician practice to provide the best care for that patient. So let me stop for a minute, see if there's any questions.
Sorry, I do have a question. So one before where you said we don't have to come out of our EHR, and so it's embedded in, is it a link that we click and then it opens it up?
Yes, with Athena, it actually is a link. And it's already there. If you kind of searched around a bit in Athena, you might be able to see that link there, and it pulls in outside documents. And so I don't know exactly what it's called, but I think if you ask your technology person there at your practice, they could help you with it.
Because yeah, they do have a good third-party app.
Yeah, well, ask them about and have them show you how it works there in Athena, because they would be able to do that.
And is it? And you said it's bi-directional. So
it is bi-directional.
And I understand, right? So you're getting data that's coming from hospitals, nursing homes, urgent cares, and all billing data. So you're also getting our data from our office. So when the PAP is performed, you know that it's done.
We don't get your billing data. We only get your clinical data. We're not involved on the financial side of the business model, partly because there are other organizations that do that, the revenue cycle management companies and the insurance clearinghouses. Our job is to get the clinical data, make sure it's clean and correct, that the labs are mapped to the proper LOINC codes and the diagnoses are mapped to the proper SNOMED codes, and make sure that the data is correct and correctly mapped. And then we'll get the clinical data to wherever you want us to send it.
Okay. Thank you.
Oh, okay. We also provide a product that allows us to provide alerts to the doctors when their patients have been admitted at any New Jersey hospital. And so today, if we are working with your practice as a physician, and we have your patient panel, we know who are the patients that you've seen in your practice because we're getting your clinical data. We generate a patient panel, and we then provide that so that we can get the alerts from the statewide health information exchange called the New Jersey Health Information Network. So NJHIN sends us all of the information, and then we send it to you as an alert. It can be sent to the physician, but most often we send it to a nurse or to a team of nurses that's managing all of the care management around patients who have just recently been admitted into the hospital. So we'll get the alert within 2 minutes of the time the patient's admitted to the hospital. And we'll route it to you within another 2 minutes of the time the patient's been admitted into the hospital. This is hugely important on value-based payment models, because if you are going to be able to keep costs low for your patients and you're going to be able to have shared savings, you need to know your patients have been admitted. You need to know your patients have been discharged. You need to know what were the reasons why your patients were admitted. So in Connecticut, we have a project that's going on right now for the cardiologists that work with Hartford Healthcare. They want to know if any of their patients, they have about 15,000 patients that they work with at the cardiology department there at Hartford. They want to know if any of those patients have been admitted with any heart-related issues at any of the other hospitals. So whether it's at Yale or whether it's at Middlesex, they want to know if their patients were admitted with a stroke. They want to know if they were admitted with heart failure. They want to know if they were admitted with any sort of significant cardiac-related incident, and they want to know immediately so that they can actually get to their patient. And so that's been something that was just recently set up. But another thing that we do with rapid alerts is for OBGYNs. We have another project in Connecticut where we alert the OBGYNs when their patient has delivered their baby at the hospital so that they actually know that the baby's been delivered. And we also can alert the pediatrician that the baby's been delivered. So there are an awful lot of things that can be done with this alerting technology, and physicians can really be able to get insights into what's happening with their patients that they haven't been able to get before. For example, one of the big projects that has been adopted now with many, many states is a product that we put together to alert the hospital infectious disease staff or the physicians that they had just admitted a patient with MDRO. And, you know, for a patient with MDRO, they have to be isolated immediately. And so the infectious disease staff rarely knows that they've admitted a patient with MDRO. But because One Health New Jersey knows that, because the data from all the hospitals is coming in to the network, and we know the patients that are on the state's MDRO list, and we know right where the patient was admitted, we can send an alert immediately to the infectious disease specialist that they just admitted a patient with MDRO. So these are some of the things that are being adopted nationwide using alerts, and we're at the forefront of really being able to pilot these because we built our own proprietary technology and we have the ability to do things that other organizations don't. I'll stop for a minute.
Sorry, the conversation up. You know how they have, Jersey has the NJIS, the organization network, and so patients can go to any pharmacy, technically for urgent care, and there are metrics. We're supposed to have their pneumonia shots. It's always missing data. That's something you get to help with that metric.
So you were kind of breaking up, but I think that you were asking about the prescription drug monitoring program.
No, actually, wait, hold on 1 second. I think it's because my.
See if that's better.
That is better. It's a lot better.
Yeah, sorry. I just realized my dictation mic was still plugged in.
So if you can repeat that question. Wait, now I can't hear you at all.
going on with this thing. How about
Now
now?
I can. Now, good.
The immunizations, so the New Jersey Immunization Network, because we have metrics for those. So for kids, did they get their flu shot, the tetanus, the seniors, the pneumavax, not pneumavax, but the PCVs? Do you get that too?
We can get it. We can get it. The states, what we do is we get the data from the primary care doctors, and then we'll send it on to the state. And so that information, we help the state get the complete and the correct set of information. But each state has differing laws on the way that immunizations can be shared. And for example, in the state that I live in Kansas, immunizations cannot be shared directly with the health information exchanges. Now, I think that's changing. And I don't know, Larry, I think this came up one other time recently about whether or not maybe New Jersey was looking at maybe changing those regulations so that physicians could get the immunizations. But I'm not sure that that's been done yet. I don't know, maybe Josh or Larry know.
Because it's the reverse, like the physician practices, we have our records, but it's when the patient goes down the shore and they get their Tdap, or they went to CVS and they got their RSV, but they're not putting it in the NJIS consistently. So
Yes, there's all kinds of problems with that. So if they go down the shore and they go to a physician practice that actually is connected into the network, then we'll have that immunization.
So
But
that's
if they go to their local pharmacy and they're giving immunizations for free on Saturday afternoon, and nobody's gathering that information is really lost. And the only thing that we can hope is that the patient actually is keeping their immunization card.
Yeah, it's been a disaster, actually.
Yeah, I agree with you. I agree with you. Okay, I think I talked about this already. So this is something that we do is really important, because what we found over the years is that oftentimes the EHR vendors have not configured the data that's being sent out correctly or completely. And so we have a team of nurses that actually will work with each facility, and they do what's called primary source verification, which is they look at the data that's in your EHR and that then is being sent out to be able to be shared with others. And these nurses give you recommendations on what they see is incorrect or incomplete in your data. And it's extremely helpful. We found some really, really difficult and dangerous situations where the EHR vendor had the labs mapped to the wrong LOINC code. And so it was very, very dangerous what was happening. So we make sure your data is complete and correct. So we deliver data in lots of different ways. So as you were asking, how can we get that data over to your vendor? Well, we can deliver the data either through an NCQA audited data stream. We can deliver it as standard supplemental data. We can get that data and actually provide it from all of the EHR systems that are in your network, and we can do it at a low cost and not burden the physicians. We have teams that come in, get it done, and get out. So lastly, I'm going to check my time here. I'm going to really quickly go through analytics. So let's talk a little bit about that. Everybody talks about analytics, and the truth is it's not very many people are actually doing it in ways that help doctors. So we do have an analytics dashboard. This comes along with your connection to One Health New Jersey, and it helps really in lots of different ways. It helps if you're in a value-based contract like an ACO. It will help you with the calculation of your quality metrics. It'll help you identify your high-risk patients. How many patients are having multiple emergency room visits in the same year and have 3 or more chronic disease conditions? If you're interested in doing transitional case management, it'll help you identify those Medicare patients that qualify for transitional case management. We've got an entire part, the north part of California, that is getting alerted when their patients with behavioral health diagnosis are admitted into the hospital, so that the community mental health centers and others can actually get there to help the patients when they've been admitted. We look at controlled substances. Actually, this was a product we built for New Jersey probably about 5 or 6 years ago to complement the prescription drug monitoring program, because what the doctors in New Jersey were finding was that oftentimes the patients were getting prescriptions, like a prescription for a controlled substance. They were going into multiple emergency rooms on the same day and getting prescriptions. And then that information, they weren't filling it. And so it didn't actually get to the prescription drug monitoring program, because the only way data gets to the prescription drug monitoring program is when it's filled at the pharmacy. So they were taking those prescriptions that they had gotten, and then they were getting them all filled within an hour, because it really takes about 24 hours for the data to be uploaded from the pharmacy to be processed and then to end back up in the PDMP program. So we built this so it would allow real-time access to prescription information around controlled substances. So there's lots of different really good analytics here. We don't really have time to go through them all, but they're very helpful. And we have probably, I don't even know it now, probably 500 different organizations across the nation that use this product. And this is just an example of kind of the way the data comes across, but this is all de-identified. If you look up here, this is really focused on readmissions, and it's kind of broken out by all readmissions and pediatric readmissions. But basically what this tells a physician or tells a hospital is a patient, and of course it has the patient's name here where it says patient name. This is just de-identified. It has your patient's name. But then it tells you the patient was admitted on 7/13 of 2022 at facility 4. Let's say that was, Barnes Jewish. And then over here, it'll tell you what the admitting diagnosis was. And then it will tell you then that, lo and behold, the patient was readmitted on 7/16 at facility 15. So what that means is that within that time frame from 7/13 to 7/16, the patient readmitted at a different hospital. Now, what we found with hospitals looking at that, they're like, well, why would that have happened? Why would they not just come back to the hospital that provided the surgery in the first place? And that's a really important conversation for those hospitals to have. Why did the patient choose to go somewhere else when they readmitted? And the other thing is that with readmission penalties, facility 4 is not going to know they're going to get a readmission penalty for that patient until they get the penalty. They have no way of knowing that patient readmitted at facility 15. And if you're in a value-based contract and you don't know these patients are readmitting until you actually get the penalties, that is not a good thing.
Can I ask a question?
Yeah, sure.
Do you also get the info, like suppose someone, just because I've seen it happen, they're waiting, they've checked in one ER, they get some services, they're waiting, it's a long wait. So they sign out AMA and then they go to another ER the same day. So do you get the diagnosis so that you would know that that's why there was two? Do you get that kind of analytic?
Probably we would not know that they signed out without medical advice. I mean, that we would not know that.
Because it's like it's in the bill, right?
All we would know is they admitted into another hospital on the same day, within the same hours.
Okay. All right.
That's what we would know. A lot of times we won't know what caused the patient to do it. We'll know it happened. They were in one hospital, 3 hours later, they're in another hospital. And that's really a little bit of the detective part, to try to figure out what caused that patient to leave that hospital and go to another hospital and choose to go somewhere else.
Laura, what we would know is if there were any services performed at hospital A or hospital B. but we wouldn't know the reason why the patient left. Maybe they felt better. Maybe they were discharged. We would know if they were discharged, right? But if they weren't discharged, I guess then you could make an inference that it was somebody left for a reason without advice.
Yes, you know, that's interesting, Larry. I've never really looked for that before, to actually see that on the discharge, whether or not the information that we get in the ADT would tell us that the patient was discharged, you know, under their own, under their own decisions rather than with medical advice. So I'll look for that and see. That's a very interesting question.
Yeah.
I'll look and see what I can find.
There's got to be a code, right? Because you get the codes.
That you would think that, yes, you would think there would be a code that would be entered in the discharge
code.
information.
Yeah. And we have in the office one, like maybe if you're tracking an urgent care that happens to be in your system, patient left before being seen by the physician. So they got placed in the room. They were, you know, maybe EKG was done, a strep test was done. They got called out because they had to leave, or they were tired of waiting for the physician, whatever it was. But they left without being seen. So those are codes that exist as well.
I am going to
Yeah.
find that out. I've never had anybody ask me that before, but I think that's really important. And so I'm going to find out the answer to that.
Okay.
So the last slide that I have here, and then we're going to pause, is that one of the things that we found for our doctors is that the actual calculation of the quality measures that they're having to provide to the health plans is often difficult. And sometimes the health plans won't accept the way the physicians have calculated them. My board chairman is a primary care physician in a 30-doc practice in Wichita, Kansas. And they have a lot of value-based contracts with different health plans. And this last year, they lost $1 million because a not-to-be-named health plan would not accept the way they had calculated their quality measures. So one of the things that we did to support physicians is that we have become one of the earliest adopters of the NCQA quality measure calculation tool. So we can take the clinical data from a practice and combine it with their claims data, and we can calculate the quality measures using an NCQA approved calculation tool and provide that information back to the practice and to the doctor about their quality measures. And they're already accredited. There's no health plan in the nation that can say that they were done incorrectly or improperly. And so they're fully accredited through NCQA when we deliver them back. So it's one of the things that we really want to help doctors with. This is an expensive, time-consuming, fraught with errors part of the work that has to be done in value-based contracting. And for us, this was one of those things where we decided we had to create a product to help physicians be able to do this quicker, easier, faster, and more efficiently and completely. So new product is ready. It's ready for the market in 2026. We're ready to help our doctors calculate their quality measures using claims and clinical data and be able to provide that information back to the health plans and to others that need that. So with that, I'm going to stop and just turn this over to KONZA Q&A and Larry and Josh and the doctors who might have some questions.
That's great. Laura, thank you so much. I actually do have a quick question. One of the complaints that I'm receiving from physicians across the state, particularly with regard to their interactions with one insurer, but I think it spans a wider range of insurers, is the issue of immediate downcoding on submission of a claim. So, generally speaking, a physician will say, I was addressing a patient's needs. The needs were complicated for reasons 1, 2, and 3, and the visit extended for a longer period of time because of those complications. I billed it appropriately, reflecting those complications, and the insurance company, without any reference to the medical record or the complication of the patient, downcoded that visit. So from a 4-level visit, let's say, to a 3-level visit. Is there a possibility that One Health and KONZA and this the exchange of data through the QHIN could be used to help smooth out that exchange of information to ensure that, maybe not ensure, to increase the possibility that insurers will actually consider the medical records that back up the billed amounts that physicians are submitting?
Well, I think the hope is that the new prior authorization requirements are going to help and support that. Those requirements go into effect in 2026 and 2027. And some of the states, and I'm not sure about New Jersey, you guys will have to tell me, some of the states we work in have implemented timelines sooner than 2026 and 2027 for the health plans to have to meet those prior authorization requirements and to be able to gather the medical records to support their denials of claims. So have you guys had any legislation that pushes the payers to get this done any more quickly?
We have had legislation around prior authorization, but it does not address the time frame that you're talking about. So maybe that's a potential area for legislative advocacy that we can pursue in the coming months and year to year and a half.
I think that would be well supported by the work other states have done around the nation. Mississippi was the first state to put in place a requirement for health plans to respond within 72 hours for acute requests. And they put it in place in 2023. They said in 2023, the health plans have 72 hours to respond to a prior auth request and order for for a surgery or something that was absolutely medically necessary. Now, they then also put in place that they had 5 days to respond on non-acute. Now, I will say Mississippi health plans have not been able to meet those requirements.
Okay.
But at least there is something that's starting to put pressure on them to be able to get the medical records for the patients, be able to evaluate the medical records, to be able to look at, for example, if they're going to downcode or they're going to deny, if they have the medical records and they have that documentation, they have at least the backup that documents that the patient does have, significant risk.
Right. Okay.
So,
Thank you for that clarification. So New Jersey actually does have a statute that's exactly what you're describing. I wonder, maybe there's an opportunity to amend that statute, which MS&J was the principal advocate for, to address not only prior authorization, but post, once prior authorization has been approved, or if prior authorization was not required for a given service, to address the downcoding issue that happens after the service is performed. So that's a great idea. Thank you for that.
If I can play on that, so can you also track it so that we can find those the bad practicing insurers that are doing that downcoding, Josh, like what you were saying? So can One Health help that way, like on the back end, so that for practices to say, hey, did you realize your last 20 submissions have automatically been coded?
The platform really isn't designed for that particular, for kind of finding payment errors. It's more for exchanging clinical information around what happened to a patient. So I would think, and my question would be, has Max or anybody in Mississippi or any of the insurers in Mississippi reached out in terms of, hey, if you can get us the clinical information that supports the prior authorization decision within 72 hours, they may be interested in being able to get that feed of information for those particular insureds. Has any discussions with any insurers there about accessing clinical data to support those requests?
Well, I mean, the problem is that the legislation, the federal legislation really depends upon the EHR vendors to implement a payer to provider API. And it gives those EHR vendors until 2027 to do it. And so what's happening is because they're not required, the EHR vendors are not required to do it, they're not. But if you recall, Larry, when we talked to Horizon, they recognized this issue. And they
Yeah.
said, we would like to use OneHealth and the QHINs to be able to get the medical records more quickly to us so that we can make good good decisions or better decisions, better decisions than what they currently are. So I do think the health plans recognize that they need the medical records. They need them quickly. They can't have care managers calling all over town,
Right.
to try to find them, and they need them quickly. And if they can get them, they can make those determinations more quickly and get the information out. So I do think that we're approaching improvements in the way the system works, but we're still probably, it's a incremental steps that we're taking.
Yeah, and I think since we do have the legislation in place now, or the law in place now that requires this quick turnaround, getting them to, and our conversations with Horizon have always, they don't really know that much about clinical data. They know a lot about claims data and billing data, but clinical information they don't know a lot about. But getting them used to using that in something like prior auth, and then I think step two might be looking at it to support a level 4 or a level 3, the same kind of clinical delivery, but for a different purpose. But they're not getting any clinical information or making decisions on any clinical information other than what you send into them and they lose 5 times and then say they never got, So this way it's an electronic transaction and we can track it. So I think it's pretty exciting that we're kind of on the verge of doing that.
I do too. I mean, it is definitely going to improve from where we are. It may take a little bit longer than what we had hoped, but it is going to incrementally improve.
Other question I had is OneHealth, when you're purchasing this, it's an all or none, or can practices purchase certain components? So like the tracking of the patients who are the, drug seeking, or, you know what I mean?
Yeah, no, what you receive is connections to the national networks, and you receive all of the analytics products. And the analytics products also includes alerts. And so all of that comes together, and it's $300 per year per doctor.
Okay. So like with us, so we had our own hospitalists, and we hit like those TCMs are for in primary care and family medicine. That's one of the biggest things that we generate, that our annual wellness is. And it's, we all know that you can decrease readmissions if you catch them within that 7 or 14 days. When we had the hospitalist service, we had a streamlined way of doing it because the hospitalist literally communicated with our case managers. We had rehab doctors, so they all communicated. Summit made a decision to get rid of our hospitalists. Many of them joined the local hospital, but the communication literally stopped. And so the care managers are trying to work on admission censuses. They miss probably 2 or 3 of mine alone a month. So we definitely can improve. I feel like that's an area we can certainly improve.
Nicole, just so you know, I talked to
Ashish?
about a conversation. He had indicated to me that they were connecting to the New Jersey HIN, but the New Jersey HIN really doesn't provide any of the analytic services that we talked about. They're just simply, a connection. So they may get information, but they don't get the analytic end of it. So if he wants to have another conversation about it, we're happy to discuss it with whoever at the group. But maybe just in your experience in your practice, you can say if you're missing 3 a month, times how many people in your department. I mean, that's a lot, right? So
Huge. Yeah.
it might be worth another conversation just to kind of model it for them and see if it would work to kind of maybe cut down some of that leakage out of the practice.
Yeah, that's exactly what I was thinking. Yeah.
So let us know. I mean, just reach out to me or Josh, or whenever you have a chance to kind of just see if they have a solution for it. Maybe they have another vendor they're working with or something. But if not, we'd love to be able to kind of pitch an idea.
And he said he was using it through a QHIN already. It's just a different vendor.
I'm sorry, I didn't understand
And
that.
he said he's already getting the info.
Oh no, they're using the New Jersey HIN, the state-based New Jersey Health Information Network at the Department of Health.
Yeah.
And I know they're probably not charging any money for it, but they're also not providing any analytics that would help identify that kind of situation. So
And they're not connected in as a QHIN. They're not getting the national data. So if there was
yeah,
information that, we talked about where, your patient got care and, in South Carolina, that information is not available to the New Jersey HIN.
Yeah. Well, like in New Jersey, it's so simple. It's the patients who call us because they know that we used to like follow them so closely. They'll be like, oh, I went to MSK in New York and I was just admitted, but we wouldn't
yeah,
get us.
yeah. That's an issue for your practice where you are. The majority of your practice is in, and you even have New York based clinics and things like that, right? So yeah, that's it. Like the New Jersey HIN doesn't even want to process data for anyone with an address that's not a New Jersey zip code. So you'd never get that from them. So, I mean, there might be something we can do to help.
Okay, great. Thanks.
So, but anyway, I see we're at time. So Laura, let me thank you for a great presentation. I don't know if there are any more questions. But this was really helpful. I see Kennedy has joined us live. I see him there in his white coat, looking dapper.
Yeah, actually delivering care for once, at the informatics space, which is increasingly where I'm heading back to because I am first and foremost a physician. So thank you for the great presentation. Um, one of my deeper questions I have, Laura, before we wrap up, is in the large health systems, especially the ones that have rolled in with a large implementation of Epic or Cerner, they're really relying on read-only access, the so-called Epic Care Link, which has become problematic. Have you, either in Kansas or across the country, have seen a use case to have practices or health systems even subsidize the cost of KONZA instead of using those read-only interfaces? Because it's again, one of the problems we face in RWJ Barnabas Health is, while our employed docs get all this rich data access within, the EHR, in this case, Epic, most of our private practitioners get an order of magnitude less because they're only having that care link. Have you seen either in Kansas or any of the other KONZA partners where you've seen health systems say, well, this is not good enough. We don't like the vendor's connectivity solution. We want to do KONZA. Do you have any use cases or studies like that?
Yeah, as a matter of fact, Hartford Healthcare is one that I've been working with just recently. They have, 6 hospitals there in Connecticut and about 150 clinics. About half of those are under Epic, their Epic instance, but the other half are on all kinds of different EHRs, some of them that you've never even heard of before. So they're wanting to get all of those integrated together so they can share data across and amongst each other. And they are using the KONZA solution to do that because it is bi-directional and allows that data to come into their EHR. But Kennedy, I don't know if you were on when I was saying, I mean, we're still seeing a lot of doctors that are on paper charts.
Yeah, I did catch that, which is absolutely shocking.
Me too. It was shocking to me. I mean, these are doctors that are practicing, in Connecticut, and they're still on paper charts. So, and we're seeing a lot that have really crummy EHRs, Kennedy.
Right.
They like built in somebody's garage, and they're still using them.
Well, and a lot of so the question, one as we close, the interesting question is how many of these would have filled the eligible provider buckets in meaningful use, right? Because we do know that meaningful use did not cover large swaths of healthcare, pediatrics, mental health, a lot of the specialty services. So do you see that because of the lack of inclusion of those specialties and those swaths, are we seeing those providers get these kind of one-off EHRs instead of the ONC certified ones, which are, again, I don't think the ONC certification meant a whole lot. I mean, and you could probably agree, but yeah, my question is how many of the non-EPs are having to catch up now because they weren't included?
Well, all of them are having to catch up because they weren't included.
Yeah.
You know,
Okay.
because the mental health providers have got to share data now. They've got to be able to get the data from the primary care doctors and from the emergency rooms. And the doctors have to be able to get the information from the psychiatrists, regarding what kind of medications have been prescribed at the mental health center.
Yeah.
So they're all having to catch up. Now, there is an EHR product called NetSmart. And it's actually out of Kansas City here where I live. It was a bunch of Cerner people who left and had non-competes. And so they built an EHR for behavioral health, and it just became a QHIN. And so that's one that actually is really, I think, delivering a good product and a good service for the behavioral health community. And then there is a EHR product called Point Click Care.
Yeah,
which is
PCC
also
for
pretty
long-term
good.
care.
Yeah, for long-term care. Again, they didn't get any money to be able to implement electronic health record systems. But those are catching up. I mean, they are catching up, but you still got a lot of folks out there in the rehab community, whether they're OTs, PTs, speech pathologists, chiropractors. A lot of care is going on out there in rehab that they don't have EHRs. So this is a long process. I mean, it really is. But I will say, Kennedy, I mean, you and I have been working on this together for many years.
Right.
Like 15 years we've been working on this together. And it is getting better. That's what I have to say.
Oh, absolutely. The statistic that I used to float out there while we still promote KONZA and interoperability is that especially in this cohort in Connecticut that you're talking about, it's been stated that physicians are missing up to 30% of the information that they need for routine clinical care, and interoperability usually fills that in. I know now, because, New Jersey, like many other states, have been saturated by Epic, just by staying in some places long enough, I'm getting the data. Yes, it's making it better. But I think that serves as a great use case for KONZA and HIEs in general, getting the data to the right places. And to close, it's really interesting with these stakeholders that have been left out by Meaningful Use One. I'm a part of the AMIA Public Policy Panel, and they started floating before this current administration. They started floating in MU2, Meaningful Use version 2 for all these non-traditional stakeholders, because right now they're struggling. Long-term care, mental health. You need the interoperability. You need to reduce the readmissions. I mean, I can tell you from the ACL I was at before coming to where I'm at now, just by saving on long-term care and reducing subacute rehab, they created shared savings. And that's all that value-based care, all that additional money that's going to be made is going to be made on interoperability, and systems are still not waking up to it. They think their EHR vendors got them covered.
Yeah. Well,
Well, I'm going to leave with one thing for you to think about, Kennedy. The organizations that really need the EHRs the most are the pharmacies. They are still on the most antiquated, basic, like Excel spreadsheets. And we need to know when patients have gotten their medications filled. And it's almost impossible to get that data from the PBMs. You pay a fortune to get it from SureScripts. And so if we could just get the pharmacies to actually implement EHR systems, the doctors would actually know what medications their patients have actually been taking, rather than, what's just been prescribed, which is so important.
Yeah. It's interesting because they want to expand their scope of practice. I don't think they should be able to do that without an interoperable EHR.
You read my mind as the latest council from the Council of Legislation. Yes, absolutely. Number one, number two. But I think it provides a really interesting take on pharmacists and access to data. I'm currently working with that on these so-called meds to beds programs. And it's really interesting on how complicated relationships can get between national pharmacies and big health systems.
It is very interesting. And I do think people are starting to understand, you know, what's happening, but it's so complicated the way the PBMs have gotten set up that it's hard to really understand it.
Well, the
Yeah,
whole-
unwrapping that is a challenge.
The whole thing with CVS Caremark, just unilaterally deciding nationally, they took Zepbound off their formulary because Wegovy gave them a much better deal. And so, I mean, it's just nuts. No appeals. You can't appeal it, which I think is illegal, right? It's patient rights.
Well,
So Dr.
Well-
Henry Dindyal, you had entered one question in chat, namely whether Dr. McCrary knows whether Village MD, present in 26 states, and City MD, a tri-state agency, are in fact part of KONZA or One Health New Jersey.
I think that you asked whether or not Village MD was part of KONZA.
Yeah.
Yeah,
Yeah, and the answer, I believe the answer is yes.
okay. I'm just saying, because it would make sense, you know, I just wanted to,
I believe the answer is yes.
okay. Right.
All right, guys. Well, thank you so much.
thank
It's
you so
wonderful.
much. Great to see you all, and
All right,
another
thank
enlightening
you.
discussion.
So
Thank
long.
you.
Thank you.
Thanks again, Laura.
Thank you. Be well.
Okay. Have
Bye-bye.
a good evening.